Welcome to the deep dive. Today we're diving into a really critical topic, cardiopulmonary arrest. You'll often hear it called CPA.
Hmm.
Basically, it's when the heart and lungs suddenly stop working together effectively.
Right, which means the body's just not getting that vital blood flow and, crucially, the oxygen it needs.
It's definitely a serious situation, yeah. But understanding what's happening is, well, I think it's really important for anyone interested in health or emergency response.
Absolutely. And we've been looking at some quite detailed medical texts. Now, they do focus on veterinary medicine,
Mm,
so animal physiology,
okay.
but the fundamental physiological things happening during CPA,
Hmm.
they're often incredibly similar across species.
Ah, I see. So even though the context is, say, dogs and cats, the underlying biology gives us valuable insights.
Exactly. You get a real sense of the core processes.
Okay, let's try and unpack this then. Our goal here for you listening is to give you a clear and pretty quick grasp of what CPA is, what goes wrong inside the body, and the immediate steps, the things that need to happen right away. We want to pull out the key information, the fascinating bits, really, without getting you too bogged down in, complex jargon.
Sounds good.
Yeah.
So let's start right at the beginning. The definition,
Mhm.
CPA, cardiopulmonary arrest, it's the stop, the cessation of effective perfusion, blood flow, and ventilation, breathing.
Okay.
And what's really striking looking at these sources is how tightly linked they are. It's stated very clearly, if respiratory arrest, so when breathing
Yeah.
stops, if that's not caught and fixed quickly, it almost inevitably leads to cardiac arrest, the heart stopping.
Wow. So time is just incredibly critical.
It really, really is. It underlines that completely.
Right. It's like dominoes falling. And the pathophysiology, the step by step of what goes wrong biologically, it sounds quite dramatic.
It is. It starts with hypoxia, but at the cellular level.
Mhm.
So the individual cells aren't getting enough oxygen.
Yeah.
Our sources say that after just, say, 1 to 4 minutes of a complete airway blockage, breathing stops. But interestingly, circulation might still be going, just for a short while.
Really? So the heart might still be pumping even if breathing has stopped
Yeah.
for a bit.
Yes, exactly. There's this brief window. It's crucial to understand that, but it is brief.
Right. Because what happens next?
Well, if that blockage continues, maybe 6 to 9 minutes,
Mm-hmm.
things deteriorate rapidly. You see severe hypotension. So a really significant drop in blood pressure.
Okay.
Along with bradycardia, that's a dangerously slow heart rate.
Uh-huh.
And you'd start seeing physical signs too, like dilated pupils. You wouldn't hear any heart sounds if you listened to the chest.
Right.
And you wouldn't be able to feel a pulse, like no peripheral pulse.
And here's something I found really interesting. After that 6 to 9 minute point, something kind of counterintuitive can occur.
Yes, the pulseless electrical activity,
Yeah.
PEA.
Exactly. So the ECG, the electrocardiogram trace, might look somewhat normal, but the heart muscle itself, the myocardium, isn't actually contracting. It's not pumping blood.
That's it. The electrical signals are firing, maybe, but they're not translating to that mechanical pump action.
Fascinating, in a grim way. And the sources also mention other rhythms that mean the heart's stopped contracting effectively.
Yes, ventricular fibrillation, that's chaotic, quivering electrical activity.
Mm-hmm.
Then there's ventricular asystole, which is just flatline. No electrical activity at all.
Right.
And, of course, PEA, the pulseless electrical activity we just discussed. Those are the big three indicating contractile failure.
Okay. So if we zoom out a bit, think about the whole body. Obviously, lack of oxygen and nutrients hits everything eventually.
Yeah, absolutely.
But are there systems that get hit first or hardest?
Yes, definitely.
Yeah.
The ones with the highest oxygen demand feel it fastest. Our sources point specifically to, well, the cardiovascular system itself, obviously,
Naturally.
the renal system, so the kidneys and urinary tract,
Okay.
and the neurologic system,
Hmm.
primarily the brain. These are just incredibly vulnerable because they need that constant high supply of oxygen to function.
Makes total sense. They're the powerhouses, right? Constantly working, needing constant fuel.
Exactly.
Now, who can actually get CTA? Is it specific types or?
Well, this is quite sobering. The sources say dogs and cats of any age, any breed, or sex.
Any. Wow.
Yeah. It really drives home that under the right or wrong circumstances, the risk is universal.
Okay. So given that, recognizing the signs quickly must be paramount.
Absolutely critical.
Mhm.
And the sources give a pretty clear, actionable list of what you or anyone should look for.
Right. What's on that list?
First, a lack of response to stimulation. The animal just isn't reacting to touch, sound, anything.
Okay, unresponsive.
Loss of consciousness, those dilated pupils we mentioned earlier. Cyanosis, that's a bluish tint you might see in the gums or tongue.
Uh-huh. From lack of oxygen in the blood.
Precisely. And then breathing. Either you see agonal gasping, which is like these occasional ineffective sort of struggling breaths,
Yeah, I've heard of that.
or just no breathing at all. Complete absence of ventilation.
Okay. And on the circulation side, what are the telltale signs?
Absence of peripheral pulses is a big one. You can't feel a heartbeat in the femoral artery in the leg, for example.
Right.
Hypothermia, the body temperature might be noticeably low.
Yeah.
And, like we said, no audible heart sounds if you listen to the chest.
Got it. Recognizing those fast is, well, it's step one for any chance of a good outcome, isn't it?
It's absolutely the first most crucial step.
Okay, let's dig into the why. What actually causes CPA? It seems like there could be a lot of things.
There are. The sources break it down into categories. One major one is hypoxemia, low oxygen in the blood.
Right.
And that can happen for various reasons. Ventilation perfusion mismatch. That's basically a coordination issue where air gets in, but blood flow isn't right to pick it up, or vice versa.
Okay, like a mismatch in the lungs.
Yeah. Or there could be a problem with the diffusion barrier itself. Oxygen just can't get across from the air sacs into the blood easily.
I see.
Then there's hypoventilation, breathing too slow, too shallow. And shunting, where blood basically bypasses the oxygenation process in the lungs.
So lots of ways the oxygen uptake can fail. What else?
Another big category is poor oxygen delivery to the tissues, even if it's in the blood.
Ah, okay, like a transport problem.
Yeah, exactly. Could be anemia, not enough red blood cells to carry the oxygen,
Right.
or vasoconstriction, blood vessels clamped down or restricting flow. Then there's myocardial disease, so problems with the heart muscle itself.
And that could be from lots of things.
Oh, yeah. Infections, inflammation, infiltrative diseases where stuff builds up in the heart tissue,
Okay.
trauma to the heart, tumors, or even an embolism, clot blocking blood flow to the heart muscle.
Right. So direct heart issues. What about like body chemistry?
Metabolic disturbances,
Ab-
absolutely big factor. This includes acid-base imbalances, the body's pH being off, and electrolyte problems. Imbalances in critical minerals like potassium too high is hyperkalemia, calcium too low, hypocalcemia, magnesium too low, hypomagnesemia.
And those electrolytes are key for the heart's electrical system, aren't they?
Vital, absolutely vital for normal rhythm.
Okay. Any other major causes listed?
Yes, several other critical conditions. Hypovolemia, just not enough blood volume overall.
Like from bleeding or severe dehydration?
Exactly. Shock, which is kind of a related state of inadequate tissue perfusion.
Yeah.
Certain anesthetic agents can trigger it.
Right. Anesthesia always carries some risk.
It does. Sepsis or septic shock, that overwhelming infection response, trauma to the central nervous system, the brain or spinal cord, and even electrical shocks.
Oh, it's a really broad range of potential triggers.
It really is. It shows how many different pathways can unfortunately lead to this critical endpoint.
Which highlights why identifying risk factors is so important if certain conditions make CPA more likely.
Precisely. And the sources do outline those. Things
Yeah.
like pre-existing heart disease, obviously, any kind of respiratory disease,
Any sense?
significant trauma, being under anesthesia, as we mentioned, septicemia, bacteria in the blood, and endotoxemia, bacterial toxins in the blood.
Okay. What else?
Ventricular arrhythmias are a big one. These are abnormal heart rhythms from the lower chambers.
Like VTACH.
Yeah, ventricular tachycardia is one example given.
Yeah.
Also things called the R-on-T phenomenon and multiform ventricular complexes, basically unstable electrical patterns.
Gotcha.
Also, increased parasympathetic tone. That's like an overactive rest and digest nervous system response that can dangerously slow the heart.
And that can be linked to?
Could be related to gut problems, respiratory issues, or even just handling sensitive areas like the eyes, the larynx, or organs in the abdomen during surgery.
Interesting.
Prolonged seizures are another risk factor. And invasive heart procedures, things like draining fluid from around the heart surgery, angiography, they all carry a risk.
Okay, so patients with these conditions or undergoing these procedures need extra careful watching.
Absolutely. Vigilance is key.
Which brings us to diagnosis. If you suspect CPA, that sudden collapse, speed is everything, right?
Everything. Rapid assessment, focus immediately on the ABCs, airway, breathing, circulation, and a quick diagnosis.
Is there anything that looks like CPA but isn't quite? Things to rule out?
Yes, the differential diagnosis,
Yeah.
things that can mimic it, like severe hypovolemia where the pulse is just too weak to feel,
Okay.
pericardial effusion with tamponade, that's fluid around the heart, squeezing it so it can't pump,
Right.
pleural effusion, fluid around the lungs, causing respiratory arrest by itself initially, or a blocked upper airway. These need urgent attention too, obviously.
And what about tests, like blood work or x-rays? When do they come in?
They're crucial for figuring out the underlying cause, but they come after the immediate ABC assessment and starting resuscitation if needed.
So stabilize first, investigate the why second.
Essentially, yes.
Mm-hmm.
Tests like a CBC biochemistry panel, urinalysis, they give clues about organ function, electrolytes, infection. Arterial or venous blood gas tells you about oxygen and CO2 levels.
Uh-huh.
And imaging, like fast scans, quick ultrasounds, chest x-rays, echo, ultrasound of the heart, abdominal scans, they all help pinpoint the cause later on.
And once resuscitation is actually happening, there are specific tools to monitor progress.
Yes, absolutely. Continuous ECG is vital to track the heart rhythm, blood pressure monitoring, pulse oximetry for oxygen saturation, and capnography.
That measures CO2 in the breath.
Exactly. It's a really good indicator of both ventilation and perfusion, how well CPR is working, essentially.
Okay. So CPA is diagnosed. Immediate action is needed. Treatment time. You mentioned CPR, cardiopulmonary resuscitation.
Must be started immediately.
Yeah.
No delay. And it's generally broken down into BLS, basic life support, and ALS, advanced life support.
Right. Let's start with BLS, the basics.
Top priority, again, is recognizing CPA has happened. Then the ABCs. A is for airway.
Okay.
Quick assessment. Is it open? Clear. You might need to tilt the head, lift the chin, pull the tongue forward.
Yeah.
Check for anything, blocking it, vomit, blood, whatever. Clear it out manually or with suction.
And then secure it.
Establishing a secure airway is key. Usually that means intubation, putting an endotracheal tube, a breathing tube, into the windpipe. If the upper airway is totally blocked and you can't clear it, emergency tracheostomy, a surgical opening in the neck, might be the only option.
Wow. High stakes.
Very. And once that tube is in, you have to confirm it's in the right place, not down the esophagus.
Right. How do you check?
Look to see the chest rise, listen for breath sounds in both lungs, and ideally use capnography. That CO2 detection confirms it's in the trachea.
Okay. Airway secured. Next is B, breathing.
Check if they're breathing on their own. If not, start artificial ventilation immediately.
Ow.
The sources suggest starting with 2 short breaths, about 2 seconds each, then check again. If still no spontaneous breathing,
Keep going.
continue ventilating at about 10 breaths per minute. Aim for a tidal volume, the amount of air per breath of around 10 millimils per kilogram of body weight.
Okay.
Deliver each breath over about 1 second. And importantly, try not to use excessive force. Keep the peak airway pressure under 20 centimeters of water if you can measure it.
Got it. And how are these breaths actually given? Mouth to nose?
Bag. Several ways. Mouth to nose, or mouth to tube gives about 16% oxygen, just what's in your own exhaled breath.
Not ideal, but better than nothing.
Right. Using an ambu bag with room air gives 21% oxygen. But the preferred method, if possible, is intubation, then ventilating with 100% oxygen.
Okay. Using an ambu bag hooked up to oxygen or an anesthesia machine.
Exactly. With the suggested oxygen flow rate around 150 milliliter per kilo per minute.
Right. Airway, breathing, brings us to C, circulation.
Check for pulses again, listen to the heart again, confirm CPA. If yes, start external thoracic compressions, chest compressions.
This is the core of CPR for many people. How effective are they?
Well, here's the thing. Even done perfectly, external compressions only generate about 30% of normal cardiac output. 30%.
That's not a lot.
It isn't, which is why internal cardiac compression during open chest CPR is mentioned as being 2 to 3 times more effective at getting blood to the brain and heart. But that's obviously a much bigger procedure.
Understood. So for the standard external compressions, how do you do them? Does it vary?
It does, based on size. For smaller animals under 10 kilos, it's the cardiac pump theory. You compress directly over the heart.
Okay.
For larger animals over 10 kilos, it's the thoracic pump theory. You compress over the widest part of the chest, using changes in chest pressure to move blood.
Interesting. And the technique itself? Rate, depth.
Aim for continuous, uninterrupted cycles of about 2 minutes if you can. The rate should be fast. 100 to 120 compressions per minute.
Wow, that's quick.
It is. And compress the chest depth by about 30%, roughly a third of its diameter.
And keep going, no stopping.
Minimize interruptions. Don't stop for ventilation if you have enough people. Don't stop to check the ECG unless absolutely necessary. And keep pauses super short.
Right.
Also crucial, don't lean on the chest between compressions. Allow it to fully recoil. That helps blood fill the heart.
Makes sense. I think I saw something about abdominal compressions, too.
Yeah, interposed abdominal compressions. Pushing on the abdomen during the off phase of chest compressions might help boost blood flow to the brain and heart if you have extra hands.
But the jury's still out on survival benefit.
Sources indicate it hasn't been definitively proven to improve overall survival, yeah, but potentially helpful.
Okay. And you mentioned open chest CPR. When would that actually be done?
Specific situations. If closed chest isn't working or isn't likely to work, things like flail chest where ribs are broken and unstable, severe obesity.
Right. Makes external compressions hard.
Exactly. Diaphragmatic hernia, abdominal organs in the chest, pericardial effusion, that fluid squeezing the heart, or just significant disease inside the chest already.
And the procedure involves?
A thoracotomy, surgically opening the chest, opening the sac around the heart, the pericardium, then directly squeezing the ventricles by hand.
Wow.
And they also mentioned possibly compressing the descending aorta, the big artery going down, to preferentially push blood towards the heart and brain.
Intense. Okay, that covers basic life support. What about ALS advanced life support?
This is the next layer, bringing in more medical interventions. The sources use the acronym DEF.
DEF. Okay, what's D?
D is for drugs.
Yeah.
And the critical thing here, drug choice depends entirely on the heart's electrical rhythm, the ECG.
Right. You need to know what you're treating.
Exactly. Common initial drugs mentioned are atropine and epinephrine, often trying to kickstart activity. Vasopressin is listed as a secondary option.
How often are drugs given?
Typically every other CPR cycle, so about every 4 minutes.
Okay. D for drugs.
E is for ECG. Electrocardiogram, like we said, accurate interpretation is vital to guide everything. Drug choice, defibrillation.
And minimize pauses while reading it.
Absolutely. Get a clear reading quickly. Keep those compressions going.
Got it. DEF.
F covers fibrillation control and fluids. If the ECG shows VFib, that chaotic rhythm,
Yeah.
immediate defibrillation is needed, and electrical shock to try and reset the rhythm. That's the fibrillation control part.
Makes sense. And fluids.
Here, the sources urge caution. Don't just pump in fluids unless you know there's been significant blood loss or the patient was severely dehydrated, hypovolemic.
Why the cause?
Giving too much fluid in other situations can actually be harmful. It might decrease blood flow to the heart muscle itself, the coronary arteries.
Okay. So fluids only if clearly indicated for volume loss. What kind of fluids?
If needed, things like crystalloids, colloids, maybe blood products like oxyglobin, which is an oxygen carrier.
Okay. And generally for giving these ALS drugs, what's the best way to get them in?
Preferred routes are listed. Best is a central vein, if you have access.
Like in the neck?
Yeah. Second best is intratracheal, down the breathing tube, but you usually need to double the dose and dilute it.
Okay.
Third is intraosseous into the bone marrow. Then, a peripheral vein like in the leg.
And injecting straight into the heart.
Intracardiac is really a last resort, unless you're doing open chest CPR. Then, injecting into the left ventricle while compressing the aorta is actually considered optimal.
Right. So ALS adds drugs, ECG analysis, defibrillation, and careful fluid use onto the BLS foundation.
That's a good summary, yeah.
Okay, so let's say the team is successful. Resuscitation works. Heartbeat and breathing are back. What happens next? Is it just...
Okay.
No.
Oh, definitely not. Post-resuscitation care is incredibly intensive. Constant, diligent monitoring is essential.
What needs watching?
Pretty much everything.
Heart rate, blood pressure, which often needs support with IV fluids, carefully given now, and maybe inotropes.
Drugs to help the heart contract.
Exactly. Monitoring arterial pressure, central venous pressure, regular blood gas checks to see how oxygenation and ventilation are doing.
Still need breathing support, maybe.
Often, yes. Continued ventilation, supplemental oxygen. Neurologic status is huge, watching for signs of brain injury from the lack of oxygen.
And treating that if needed.
Yes, treatments for potential brain swelling or increased pressure might be used things like mannitol, corticosteroids, diuretics like furosemide.
Okay. What else?
Continuous ECG monitoring for any returning arrhythmias. Tracking urine output tells you about kidney function, body temperature. Repeat chest x-rays to look for lung damage from the CPR itself or underlying issues. And crucially, still trying to figure out and treat the original cause, right?
Absolutely. That has to happen concurrently. You have to fix what caused the CPA in the first place, if possible.
Right. Now, is there anything about prevention? Can CPA be prevented?
The advice is quite straightforward, but vital. Careful, continuous monitoring of all critically ill patients.
So catching problems early, before they escalate to full arrest.
That's the goal. Proactive monitoring allows for early detection and intervention.
Makes sense. Finally, what about complications? Even if resuscitation is successful, are there potential problems afterwards?
Yes, unfortunately. The event itself and the resuscitation efforts can lead to complications. Things like vomiting.
Which could lead to aspiration pneumonia?
Exactly. If stomach contents get inhaled, fractured ribs or sternum from compressions, bruising of the lungs, pulmonary contusions, fluid in the lungs, pulmonary edema,
Okay.
pneumothorax, collapsed lung from air leaking into the chest space, acute kidney failure,
Mm.
neurologic deficit, sadly, due to that oxygen deprivation to the brain,
Yeah.
and recurrence of cardiac arrhythmias.
So survival is just the first hurdle. Recovery can be complex.
It absolutely can be.
Okay. So let's try and wrap up this deep dive into cardiopulmonary arrest. We've covered quite a bit.
Yeah.
We saw it's this sudden, life-threatening stop of effective heart and lung function.
Triggering that damaging cascade throughout the body.
We really hammered home the need for rapid recognition of the signs.
Yeah, and immediate effective CPR, both the basic and the advanced life support steps.
And we touched on the huge range of things that can actually cause CPA and the potential complications that can follow even successful resuscitation.
So hopefully you, our listener, now have a solid foundational grasp of CPA. You recognize the urgency, the complexity.
Yeah, what's involved.
Exactly.
And maybe a final thought for you to chew on. Just consider how incredibly interconnected everything in the body is. CPA really throws that into sharp relief, doesn't it?
It really does.
How a failure in one system can just spiral so quickly. It makes you think about, well, the body's resilience, but also maybe the limits of what we can do when things go that wrong. What questions does that bring up for you about life's delicate balance?
It's definitely profound stuff, and we'd encourage you, if anything specific caught your interest, maybe the different types of hypoxia or the details of CPR techniques, definitely dig deeper. There's always more to learn about this critical area.